Today we present Navigating the Vascular Maze, Managing Uterine Arteriovenous Malformation. Today's objectives will be to review AVMs and the treatment options. We will then present our surgical approach to a hysterectomy for a large AVM. We present the case of a healthy 26-year-old G2P2 with 2 previous C-sections and no other uterine instrumentation. She presented multiple times to the emergency department with significant vaginal bleeding, which did not improve with OCP and TXA. An ultrasound revealed a large vascular abnormality with a peak systolic velocity of 150 centimeters per second. As we can appreciate it here, the MRI revealed a significant uterine AVM. AVMs are vascular fistulas, defined as an abnormal connection between arteries and vein. They are rare, but the associated bleeding can be life-threatening. They are either congenital or acquired. Although angiography is the diagnostic gold standard, ultrasound is an emerging and promising modality. Multiple risk factors have been identified for acquired AVMs, such as any disruption of the uterine cavity. Other factors are malignancy, gestational trophoblastic disease, infection, and DES exposure. Given the absence of standardization, treatment selection algorithms have been hypothesized in the literature. Expectant management would be acceptable in small AVMs with a slow peak systolic velocity. For larger ones with a PSV between 40 to 60 centimeters per second, medical treatment would be recommended. An interventional approach is favored with faster PSVs. Patient factors also contribute to treatment selection, including age, hemodynamic stability, fertility goals, and overall patient's perspective. Given the clinical picture, the patient's fertility goals, and the size and the PSV of the AVM, an interventional approach was favored. The patient was therefore offered embolization or a hysterectomy. Interventional radiology was consulted, and a CT angio confirmed the AVM. Here we can appreciate the angiogram showing bilateral AV shunting, and that no AVM nidus remained following temporary occlusion. As such, according to IR, embolization was reasonable, but they cautioned against systemic embolization risk and the risk of failure. The patient opted for a hysterectomy, for which she was consented. For pre-op planning, we recommend the following: ensuring patient's understanding of procedure's implication, anemia optimization using IV iron and TXA, pre-op cross-matching of at least 4 units, a chest x-ray to rule out gestational trophoblastic disease, vascular surgery on standby, and a pre-op IR consult for internal iliac balloon placement to be inflated intra-op. Intra-op, we advise securing the uterine blood supply before placing a uterine manipulator to avoid AVM disruptions. Blood supply can be secured by ligating the uterine arteries or the anterior division of the internal iliac. IR balloons can be used as an alternative or an adjunct. Against the usual instinct, we encourage dissecting closer to the bladder to avoid the AVM. Starting on the right side, we identified the right ureter and the obliterated umbilical artery, above which we opened the retroperitoneum. Of note, to avoid using the uterine manipulator, we divided the mesosalpinx and uterovarian pedicles first to improve exposure to the sidewall. After uterolysis, we used the obliterated umbilical artery to identify the uterine artery origin and the anterior division of the internal iliac, 2 centimeters below the iliac bifurcation. We ligated both arteries with metal clips. Anatomical variations may impact the feasibility of securing either vessels. We showed both given accessibility, AVM size, and for teaching purposes. The same procedure was then reproduced on the left side. After securing both vessels, we then placed the uterine manipulator under direct visualization. Of note, in our institution, we use the Rumi manipulator. We then turned our attention to the bladder. Given the central position of the AVM and the previous C-sections, we favored a lateral to medial approach. We used a combination of monopolar cautery and ligature sealing device to dissect the anterior leaf of the broad ligament. Given the dense adhesions between the bladder and the uterus, we inflated the bladder with the CO2 gas from the laparoscopic setup to outline the borders of the bladder. With traction and counter-traction using the laparoscopic instruments and the uterine manipulator, we identified the level of the pubocervical fascia. Once both uterine arteries were transected at the internal os, we tunneled our instruments under the adhesion formed by the previous C-section scar at the level of the AVM. This freed the bladder. We alternated between both sides as the dissection became easier, with every millimeter released on either side. Once the adhesion was completely skeletonized, we were able to divide it while remaining closer to the bladder to avoid the AVM. We then completed the colpotomy and extracted the specimen vaginally. We then sutured the vaginal vault. Here, we can appreciate the integrity of the bladder wall during cystoscopy. The patient had an uncomplicated recovery, and she was able to be discharged on post-op day 1 with an adequate hemoglobin. In conclusion, when dealing with AVMs, a multidisciplinary approach is strongly encouraged, especially with interventional radiology. If surgical approach is chosen, efforts should be directed at decreasing the blood flow to the uterus. This can be done surgically or with IR balloons. Lastly, against usual instincts, it is important to stay closer to the bladder while dissecting it to avoid the AVM.